Hello, welcome to another episode of hearing me and Tausif speak about many different foot conditions of the podiatry detectives. Now, Tausif has really gone upscale now. He has got an amazing background, and I am jealous. I am actually jealous of his background. I thought mine was pretty cool, but now, yes, the movement therapy and Colombo. Well, hello, Colombo. How you doing, mate?
How are you?
I'm good. I'm good. Boris Johnson, is it a baby boy? Did you hear that?
He did. Yeah, he did.
You know he's got 6 children from before.
6? I never knew
Yeah.
that. That
And he's not even Asian. He's not even Asian. He's got 6 children from before. So today,
he does look very weak, doesn't he, Boris, following the coronavirus thing?
Yeah, hopefully we should hear some more updates today, actually. He's going to be doing that. He's going to be leading it. So we are going to be talking today about heel pain, and my friend and colleague Tausif is going to be leading it. Now, I normally ask Tausif a question to learn more about Tausif, and I haven't prepared this one at all because I just thought now I have to ask him a question. So let me think of something that would make him, actually, it'd be a nice simple question. This would be easy for you. Tell me what your favorite food is. So especially now that you're fasting, what's your favorite food?
Now that I'm fasting, I can give you a list as long as my arm, because that's all I think about, and that's food. I think my favorite would be kale. It's very unusual, but it would be.
You like kale? Please, you can't. That can't be your favorite food.
It's my favorite food because it's got lots of memories associated with it. Because I used to go with my grandma to the fields. We used to pick it off together, come back home and cook it. Of course, I couldn't cook it, but she would. But I've got lots of memories with it. But strangely enough, kale is my favorite food.
Okay, you are too much of a health freak.
Nothing,
okay, shall we?
Nothing to do with health. It's just food.
Shall we start? Because we've got a lot. We've got a lot to cover.
Absolutely. So we're going to open up, or let me do the screen share first. Presentation. Okay. So can you see my?
You want to put it on the first slide?
Let's do that.
And run the slideshow. Hey.
Right. Today we're going to be talking about heel pain. And Abid, we know that heel pain can be millions and millions of different things which can actually affect heel pain. So what we've focused on is the few different conditions which we commonly see, but predominantly we focused on one condition which is the most common condition we tend to see in our clinical settings, and that is plantar fasciopathy. So, right. So heel pain, we put plantar fasciopathy right at the top. So we're going to be going into a lot more detail about this. So we're not going to mention that here. So fractures. Fractures could be another cause of plantar heel pain. So calcaneus, which I show you around here on the, it's the biggest bone in the foot. And due to traumas, due to accidents and stuff like that, as well as repetitive stress, can cause calcaneal fractures. That can be one of the conditions which can actually affect and cause the heel pain. We can usually, I don't tend to see that very often in the clinic, but few runners who have actually come in with the heel pain. What about you?
I've seen quite a few, but it didn't. Before they get a fracture, they get a bone stress reaction injury. So it's the precursor to a fracture, which essentially is like a bone bruise, and they'll get bony edema. We can diagnose it quite easily in clinic. Ultrasound's quite good because there's quite a high signal coming from the center of the calcaneus, usually, of the heel bone. But a bone stress reaction injury in the heel can happen to footballers, especially that are playing on those 4G pitches, and they move from different surfaces. Sometimes they play on grass, 4G or AstroTurf. It can happen to runners when they cramp up their load. But yeah, it does happen.
Okay. Bursitis is there is a bursa which sits right underneath this heel bone, which act as nice cushioning for every time that we actually do the heel strike. Itis means inflammation, as we mentioned in our previous episodes. So that bursa can get inflamed due to a number of reasons. That can be certain medical conditions which can cause that, or excuse me, that can be again overuse injury. That can be the loading and stuff like that can actually cause the inflammation of the bursa. Again, I do see that quite often in the clinical setting of it, and they're fairly easy to diagnose. The presenting symptoms are quite simple, and bruising sort of pain, dull aching pain. A lot of the time you can actually see that their plantar fat pad has splayed underneath, and they've exposed that pressure, the heel bone a lot more. A lot of people who have got like thinning of the plantar fat pad often basically suffer with that. Would you agree?
Completely agree, yes. Yeah.
So they're quite easy to treat, aren't they?
Yeah, I just offload it for a little while. Tends to heal quite well. Don't really need to do much more to that. Yeah. Apart from just letting it heal.
My take on these things is that a nice cushioned orthotic enclosed shoe have a nice sort of deep heel cup, which basically prevents that splaying of the fat pad, and that acts as quite a nice sort of cushioned and keeps that heel nicely encompassed, and helps with the resolving of the symptoms.
Absolutely, absolutely.
Now, tarsal tunnel syndrome, how would they get that?
Yes. Tarsal tunnel syndrome. The tarsal tunnel is an area on the inside of the arch, just above the heel, where the tibial nerve runs, and there's a neovascular. There's other structures there, so you got vascular structures there as well. It's often misdiagnosed as plantar fasciitis, plantar fasciopathy, and essentially it is like a neural entrapment rather than a problem with the fascia. We can diagnose it quite easily in clinic just from taking the history and palpation. The symptoms will be a lot more different. However, you can get tarsal tunnel syndrome and plantar fasciitis or fasciosis at the same time. So that has a unique set of challenges. Very easy to treat. I inject these. I was injecting them 2 or 3 a week before COVID. Very easy to treat and resolves a lot easier than plantar fasciopathy actually. But yeah, would you add anything else to that?
No, in terms of the clinical history, some of the signs with regards to the nerve-related pain would be tingling and numbing sort of sensation as compared to sharp shooting pain. You can have sharp shooting pain, but it'll be associated with the numbing and the tingling, and hence that can give you a clue, doesn't it?
Absolutely, absolutely. Yeah.
Achilles tendinopathy, although it is at the back of your heel rather than at the bottom part of your heel, but the insertional and Achilles tendinopathy, as well as a chronic, which has been there for a very long period of time, that can mimic as a plantar fasciopathy, can't it?
It can mimic as heel pain, but the site of pain will be a lot more different than what we normally get.
I find that when it gets into more of a chronic sort of condition, the whole heel start to actually hurt. And when patients are consulting Dr. Google and they search on Dr. Google and they say, right, heel pain, and they end up with the plantar fasciopathy, and they keep on doing the exercises for plantar fasciopathy, but don't really get anywhere with the Achilles tendon. So in the clinical setting, if you come to see Abid myself or any other podiatrist, they should be able to diagnose that or differentiate between these two quite easily. However, when you're consulting Dr. Google, you generally can mix it up with the plantar fasciopathy, can't you?
Absolutely. Insertional Achilles tendinopathy is one of the banes of my life. It's very difficult to treat. And this will be a different talk altogether, but it can present as heel pain, and we generally treat it slightly differently to plantar fasciitis. We're giving you more heel raises rather than an arch support, and we may go into a lot more detail regarding insertional Achilles tendinopathy, but yes, it can present as that. Sever's disease. Sever's disease. Do you want to explain? Well, first of all, what is Sever's disease?
So Sever's disease again is associated with Achilles tendinopathy, where there is the growing. It's more common in children. I think the ages of like 10, 11, 12, when they're about to grow. So it's a clinical fasciitis. I think there's a bone traction in around Achilles, where Achilles tendon inserts into it. So very common in children, and quite easy to treat, isn't it?
It is. Because of my role with the Birmingham Youth Sports Academy, I've seen quite a few young footballers with this. Can be easy to treat, but sometimes this can linger on for a good 18 months, even with all the best will in the world. Now, just give everybody a very brief anatomy lesson. When your bones are growing when you're a child, the ends of the bones are not completely formed into the main area of the bone. That happens slowly over time, and normally that ends by the time you're 15, 16, right? But when you look at an X-ray, you almost think that they've got an extra bone. They have, or like a fracture, but they haven't. It's just that their actual like growth plate hasn't joined onto the main bone. When this often happens in young boys, footballers, that are doing too much too quickly, and at that age you think that you are invincible, and then this kicks off, and then it can be very hard.
Well,
Yeah,
Abdullah, who's 10 turned 11 in the March. We've been running and we've been doing couch to 5k, and he joined me with the couch to 5k. And what does he want to do? He wants to run ahead of everybody, and he wants to win the race. And in fact, he was asking me yesterday. So he developed Sever's, but which settled quite quickly because his dad is an awesome podiatrist.
Okay, great. Do you want to move on to see?
Right, plantar fascia fact. Chronic plantar fasciitis is the most common foot complaint affecting about 10% of the population and accounting for more than 1 million doctor visits annually. Now that
how many don't visit their doctor and they just look it up on Google?
Absolutely. And that is a lot. And this is more chronic, not even acute. And I often complain about these things, is that patients don't come to see you soon enough, do they?
No. So you're very, I mean, look, I don't think the mindset has been really enhanced in patients where if they have a foot problem, they go and see a podiatrist rather than their GP. The GP, I think GPs are great for big things like blood pressure, diabetes, etc., etc. But when it comes to things like foot pain, they think all heel pain is plantar fasciitis rather than everything else, and then they think that all plantar fasciitis should be treated with anti-inflammatories, and they'll give you a sheet that they might have print. If you're lucky, they'll have a sheet of exercises that they'll give you. They won't be able to demonstrate it, and oftentimes, as Tausif will tell you, they do them wrong. So sometimes visiting the GP may agitate the plantar fasciitis or plantar fasciopathy even more, even with all the best will in the world from the GP or the doctor. Would you agree, Tausif?
Absolutely. Now, there are It's a minefield. There are differential diagnoses of heel pain. It could be arthritis, different types of arthritis. It could be infection. It could be infection because of diabetes, osteomyelitis. It could be as simple as plantar wart, which is verrucas. Neuropathic pain. I've seen a number of people started to come through with lumbar radiculopathy, which is referred sort of pain in the heel because of impingement in their back, nerve impingement in their back. Yeah.
Sciatica pain.
Sciatica and similar type of impingement. And we talked about the tarsal tunnel, localized nerve impingements as a differential diagnosis. And there can be trauma as a fracture, tumors, neuromas, and it could be vascular as well. Vascular is fairly rare, but yeah, it could be anything.
Yeah.
Do you agree? Anything would you like to add to that?
No, I mean you've covered almost everything. There are a couple of other like inflammatory arthritic conditions that can lead to heel pain.
We've got some examples of inflammatory arthritis like gout, rheumatoid arthritis, seronegative, ankylosing spondylitis, so spondylo.
But that doesn't mean this does cover most of it. This does cover most of it.
Okay, so it's very important for people to know that not every heel pain is plantar fasciopathy.
Go and visit a podiatrist.
Right. So, what is plantar fasciopathy then, Abid?
Well, let's explain what the plantar fascia is before we explain the plantar fasciopathy. Now, the plantar fascia is a thick fibrous band that connects from the heel to the toes. It actually goes into the plantar plate, which is something that we spoke about last week, and it acts as a shock absorber, helps to maintain the arch. Now, there are various schools of thought regarding plantar fasciopathy. Some people think that it is a degenerative change that occurs within the fascia. Other people think that it is an inflammation that occurred that hasn't settled, so you've still got inflammation going on within that structure. We know now that generally there's not much inflammation going on. There's more thickening of the fascia. So when we do an ultrasound, normal fascia is about 3 to 4 millimeters. When we do this, when we do an ultrasound to this, it can be as much as 6, 7, 8 millimeters. One of the things, I'm not sure if you've got the slide there. If you have, please tell me to stop. You can get a tear within the fascia, which is treated slightly differently, and that could be like a sudden pop, you'll feel the difference. Normally plantar fasciopathy, it's a gradual process. It's not like, you wouldn't be able to, if I asked the patient, tell me the date and time when this first started, they won't be able to tell you. If they've tore it, they'll be able to tell you. That's right, yeah.
Right. I must say, I am
tell us about the
slide presentation. Right, so
I can see how happy you are with your. I can just about hear you.
Can you not hear me?
I can hear you now.
Okay.
Is your speaker too loud or something, or do you wanna?
I think I'm on my laptop, so I haven't changed anything.
Okay, cool. Do you want to go over the risk factors?
So risk factors, there's lots of risk factors for plantar fasciopathy, but I generally tend to cover the common ones which we tend to see. And if I haven't, I'm sure you'll be able to add that to it. So age-wise, commonly seen in 40 to 60-year-old individual when you put it in terms of the age. Obesity is something which is seen often with the condition, and I suppose that it makes sense, doesn't it? So the increase the load on the fascia, and the more chances of you basically causing that overuse injury. Foot mechanics, there's a lot of evidence with regards to certain mechanics causing or being a causative factor in plantar fasciopathy, be it flat feet. Like 4 in 5 patients who suffer with plantar fasciopathy will have pes place. Flat feet, I'm going to keep it simple. Flat feet. Of course, it can happen in high arches as well. Gait abnormalities is quite often seen with patients who have plantar fasciopathy. One of the most common things that I tend to see is the reduced ankle dorsiflexion, which means is that reduce the ability of the ankle to move upwards, as well as if there is a big toe movement which is affected, so there's not enough movement in the big toe, whether that is due to the functional, because the foot basically flattens out and that stops the toe moving upward, whether it is because they don't have they have arthritis in their big toes and there's not enough movement. That can be causative factors when it comes to foot mechanics. Occupation, so anybody who's been standing on their feet for like 8, 10, 12, 14 hours a day tend to have, that can be a risk factor for it. People who are working in the restaurants, people who are on as cashiers who are on their feet all the time, they tend to suffer with it a lot more than anybody else. Exercises, again, in terms of the exercises, type of exercise, the intensity of exercise, frequency of the exercise, and how quickly you increase your exercise is another causative factor for plantar fasciopathy. Anything you'd like to add, Abid?
Couple of things. First of all, I think I see this quite a lot in the 30 to 40-year-old range as well. That could be for a variety of reasons. Occupation, definitely, especially if they're standing on hard concrete surfaces, that could make a big difference to getting something like plantar fasciopathy, because they can get fat pad. Give me a second. I think it's my internet connection, actually. It's a bit unstable. Can you still hear me, Tausif?
I can. You went off for a second, but you're back on.
Exercises, yes, they're definitely, if those people that are doing HIIT classes with a lot of box jumps and burpees, they're putting more strain through the fascia, then that can be one of the underlying reasons for it. But yes, I agree with you.
Symptoms. A lot of the time, plantar fascia can be diagnosed with clinical history as well as the clinical presentation. And when we talk to them, it's very often that patient would say that they get sharp shooting pain, which is first thing in the morning, or if I've been sitting for like 2 hours and then I step up and I want to walk off, and it gets, it basically eases gradually as they start walking with the activity, so the pain tends to disappear in early stages, but when it gets to the chronic stage of plantar fasciopathy, the pain tends to lingers around pretty much all the time with any activity, doesn't it?
That's right, yeah. Agree completely.
So again, we talked about the diagnosis. Clinical history and the clinical examination is usually more than enough for us to kind of diagnose the plantar fasciopathy. It's quite, I've got this very ruthless way of testing it. I tend to basically palpate around it quite nice and gradually. And if somebody had the pain for a long period of time, they tend to get the diffuse pain in other parts of the heel as well, don't they?
Yeah.
So when you press around the area, they would say, oh, that hurt, that hurt, that hurt. And then you just literally press on the tubercle of the calcaneus where plantar fascia inserts, and they just go through the roof, don't they?
Completely. I'll add one more thing to that. So what we would both do also is squeeze the heel from the sides. So if they were getting pain from that, we may be thinking that they've got an inflammatory condition, or they've got a stress fracture, or they've got something else, because we're squeezing the pain, both heel. If they're like jumping through the roof with that, then that would be quite right. And as Tausif said, we would find on the inside of the heel there's a little ridge that we know where it is, which is where the fascia comes. When we palpate that, it is very painful, very painful. So that's the medial tubercle of the calcaneum.
Yeah, it's important to mention here that just because somebody comes in and says, oh, okay, I'm getting pain first thing in the morning, and this is the kind of pain it's like, we don't assume that they've got plantar fasciopathy, do we? We still do all our examination, all our testing to rule out the other possibilities as well. As you previously mentioned here, is that sometimes sinus tarsal tunnel syndrome and plantar fasciopathy can actually present, it's like both of them can be there, can't they, at the same time. It is not not uncommon that you tend to find like several conditions present at the same time.
Yeah, so one of the other tests that we do is Tenel's test, which is where we basically move the foot and we tap the nerve. If that's sort of sending you to the roof, then we know that there's a problem going on with the nerve as well. But as Tausif mentioned correctly in the second sentence, an ultrasound examination for this is a great tool that we can quickly do in the clinic, that we can measure the fascia and we compare left and right, and we know what approximately normal is, and we can measure it. And sometimes you can see that there's disorganized fibers within the fascia as well. So it comes across different to a normal healthy fascia. Would you agree, Tausif?
Definitely, and I've started using ultrasound in terms of pre and post as well, that you generally tend to see that there is that reduction in thickness following the rehabilitation plan, if you've given an injection, and once it actually gets better, you can see that the changes in there as well. So it's quite a nice sort of assessment tool, not just to identify, to reassess it as well.
Absolutely.
Yeah. MRIs? Not really.
I have sent a few patients, normally when they're not responding to conventional treatment, and I'm thinking, have I missed something out? Is there something not right? And sometimes, as I said, some of my elite athletes, they'll come with a physio and they'll say, I want an MRI. Fine. So that will be, I mean, once I've got an MRI, I've got a big picture. But that being said, sometimes MRIs you'll get findings that are non-significant findings that you have to be very careful when you start talking to patients about, because if you MRI most people, there may be something that's not quite right, but it's causing no symptoms. So you may be opening a can of worms. But as Tausif will tell you, we do not treat scans, we treat the person.
Yeah, absolutely.
Okay.
I suppose the MRIs is, as you rightly said, if things aren't getting better, that's when I would be considering MRIs. Otherwise, usually plantar fasciopathy can easily be diagnosed and treated with just hands-on assessment, clinical history. Ultrasound examination gives you that detailed information that you require. MRI, as said, only required when things aren't heading the right way.
Okay.
Right, treatment. I must say that I quite like peace and love. So I suppose in acute stages, peace and love is great. Abid, would you like to quickly explain what peace and love is? Because
I'm gonna forget it all now. Protective loading, E is for elevation, A is to avoid anti-inflammatories, C is for compression, E is for education, and then L for the love was to load it. O was for optimism, feel good that you're going to get better. And you know what? That is probably, as I'm getting older, and I've been a podiatrist for too many years, optimism is becoming a really important thing for when I'm treating athletes. And it's the whole biopsychosocial model is becoming more evident. V is for vascularization, so do an exercise that you can get some blood flow going in there, and I think E is just doing exercises.
I'm impressed.
Yeah.
Right, so we're going to be talking about these things in a little bit more detail for all the others, but with regards to the painkillers, what's your take on painkillers? For me, I don't mind them early stages if patients have got like lots of pain and that's stopping them doing what they, even weight bearing and stuff like that. I don't mind them using them for short term.
My view on this has evolved over the years. I was really anti-inflammatories, really anti-inflammatory. Now I think
I put painkillers. I didn't put like anti-inflammatories. I put painkillers there, and the reason is that the thing which I want from that is pain reduction. I'm not interested in.
Okay, so I'm going to be. I think paracetamol, no. I think anti-inflammatories for a short duration, yes. Because if it allows, and I don't think it's going to reduce inflammation because there's no inflammation there, but I think it can modulate their like response to enable them to do the rehabilitation program effectively.
Yeah.
And sometimes it's the patient needs it to get through their day for the first few days because they're in that much pain. But yeah, paracetamols, no, generally. Taping.
Now, taping is something which a patient, I don't know how your model works when you see the patients and how do you give them orthotics and when you assess them, what do you do? But for me, the process is like this. So when they come in, I've assessed them, I've identified them, I've educated them, and I don't issue orthotics straight away in the first appointment at all. So I would tape them. I would show them how to tape themselves. So here is the low dye taping, which is very much researched tape, isn't it? There are lots of sports taping, like kinesiology taping, which absolutely everybody loves because the colors are vibrant and it's not very aggressive. There's stretch in there, so people can actually comfortably wear it. Short term, I like it. I think whether it is a placebo effect, whether I don't think that the things that they claim that the tape will do, it does do it. But it definitely helps my patient in terms of pain reduction, them feeling better. They can achieve more in terms of like the activity, so they can they feel better with it as well. And again, you would Google it and you'll see lots of techniques of taping for fasciopathy, for all these things. Generally, when I'm taping what's in front of me. In terms of if the foot is flattening out too much, I might actually have a bit more of an added support in the arch and try to reduce the stress on the plantar fascia in terms of movement rather than just picking up the tape from the Google and saying that one here and one there and that's it, that's your plantar fascia taken done. Would you agree? Anything you'd like to add?
No, I think you covered it. I tend not to do as much taping as I used to do. I've evolved from taping too, but I do sometimes certain patients to get them through a certain activity. I will tape them. But yeah, I agree.
So for me, like the way I do it is that initially they have it for first couple of weeks, they have it all the time. Then it is with a particular sort of activity. As soon as I've got the orthotics in there, then it's pretty much if they are running 10K, for example, and I want them to have that added sort of support, and then I'll do it.
So I think, I mean, you're adding a compression to the structures, and I find there's a plantar fascia sock, which is like a compressive sock, and I think it does the same sort of thing clinically without being so fiddly. But yeah, I completely agree with you. Do you want to move on to the next one?
So,
right.
So now we're going to go through several exercises, which will include some mobilization, some stretching, and strengthening exercise video.
Tell everybody what is the Ratcliffe procedure. So you've got, this is a very, very good exercise. Okay. Some people get agitated with this. Some people don't. But if you want to go through what is in that picture that is on the right hand side of the screen.
So in terms of that's how you do the Ratcliffe protocol, where you roll a towel. You would put that at the end of the stairs, as demonstrated in the image. Make sure the toes are dorsiflex, which is moved upward. That increases the traction and loading on the plantar fascia. And then initially, you can do it with 2 feet, and you can basically progress that to 1 foot at a time.
What are you doing? Tausif, what are you doing?
So technically, what you're doing heel raises. So
okay.
It works like this. So you count 1, 2, 3. So that's when you go upwards. Then you hold it for 2 seconds. You count 1, 2, and then you do 1, 2, 3 to basically lower it down. So it includes like 3 sort of movements. So you have like eccentric loading, you have concentric loading, and you have 2 seconds of isometric loading at the top of the range as well.
Are you going below the step?
Pardon?
Are you going below the step? Are you taking the foot below the step?
Again, this exercise very much depends on their ability and what they can tolerate. So if they can't tolerate going down, then what I would do is that I would basically stop in the mid-range. If they can tolerate it downwards, I would go slightly down, yes.
Okay. How many reps would you recommend?
So again, this is every other day. There is, you initially start off with a set of 12 rep maximum. So being rep maximum, meaning that at the 12th number, you need to have that fatigue and you shouldn't be able to do any more than that. That means that it's high strength loading. If you can do, for example, if you're on both feet and you can do like 30 in one go, then that means that you're not achieving what you want to achieve. So you might want to basically move on to the 1 foot. It's something I work with the patients when they are in the clinical setting with me. So I would go through these exercises with them, identify their baseline, and from there, we would basically have our rehab plan. So this is a very good paper from Ratcliffe, which talks about all this. But I individualize it in terms of the reps and in terms of the sets. And
how many sets do they generally do?
They generally have 3 to 4 sets of 12, and as you move forward, you can basically reduce the reps and increase the sets. So if you come down to like 10 rep maximum, 8 rep maximum, then you go to 4 sets and 5 sets.
Okay, great. Okay, cool.
Yep. Have you ever used plantar fasciitis fighter?
I have. I'm not a big fan, to be honest with you. I understand it's basically doing the job of a towel. Mm-hmm. So it's just dorsiflex. It's moving your toes upwards. I've had a little play around with it. Mm-hmm. But yeah, have you had a play with it? Have you got one?
Yeah, I quite like it because for a few reasons. Is that a lot of the time I tend to go through with my patients doing the exercises. They do them with me one-to-one. So I know and I educate them what is the actual dorsiflexion I'm looking for, whether they have enough or they don't have enough. And with this, I don't have to worry about it. They can just, I know that they're going to be getting enough dorsiflexion there.
Okay.
Right, so this is the exercise I generally like to do.
Sit on a chair or on the floor.
I'm going to take the volume down. So technically what you're doing is that you're basically pulling the toes back and getting the stretch in your plantar fascia. It's something which I recommend my patients first thing in the morning. I always say that use a thumb and just do a little bit of a massage, or if you've been sitting down for a little while, I get them to mobilize the fascia before they put their first step on the floor, and I think it helps. What about you?
Completely agree. I also tell patients to do it. Just like you, when they do it, I get them to get some arnica cream or a different oral oil, and I get them to massage while they're doing it. It's an absolutely great exercise.
Because I find that in early stages, or in predominantly most stages of plantar fascia, the pain is first thing in the morning. So this certainly helps with that.
Okay.
So the second exercise, which again,
take a bottle of water and freeze it.
It's quite nice when patients have been on their feet for a whole day, or they've been doing some exercises and the heel is sore. So if you have a bottle of water, you've frozen it, and then you put it on the floor, and you can just literally use that to roll the foot. You can use a tennis ball, you can use golf ball, you can use can of tin beans. Basically, the aim is the ice would basically numb the pain, and with that circular sort of movement, you're just mobilizing the fascia.
I agree. I tend to progress them from the ice bottle water to a tennis ball and then a golf ball, because it becomes progressively more difficult. But yeah, I do agree. It is a good technique to use.
So in terms of stretching and in sports world, stretching is kind of going out of fashion, isn't it?
There's some evidence to say that static stretching, which is what you're about to show now, is not effective. But I think they're more focused. Athletes are more focused on dynamic stretching now.
Yeah, so I still like stretching for the calf muscles. I think there's a number of reasons. A lot of the time, patients come in with plantar fasciopathy. They have reduced movement in the ankle dorsiflexion, so I quite like it, and it gives that pain sort of act as a pain reliever as well.
The video,
a pole they can see. Or other support.
So this is, I think this is the video for gastrocnemius, which is the main muscle on the calf. Yeah, that's that. So what you do is you'd stretch the calf muscle and you hold it for 30 seconds. That's what I like. Do you like it longer than that or shorter than that, or?
30 seconds is fine. Couple of pointers. I like the patient to maintain their core. I like for them for both feet to be relatively straight. So they're not. If you've got the foot too far out, it's too easy to do. But yeah, I tend to give almost everybody plantar fasciopathy heel pain. I want to just briefly touch upon this without going into too much detail. Now, there is a school of thought that the entire body is connected, and all the fascia in the entire body is connected. So when we stretch your calf muscle, which is further up, we're actually taking the strain off the fascia, off the Achilles tendon, and we think that the Achilles tendon branches out into the fascia. So we think it's a continuation of the Achilles tendon. As Tausif rightly pointed out, a lot of them have stiff ankles, they have tight calf muscles. When we take that strain off the calf muscle, it also affects the fascia. Briefly, I'm not going to talk about this too long, but this is why sometimes I give acupuncture in the calf and the foot gets better because of the interconnected nature. I don't do as much acupuncture as I used to do back when I was a younger man, just because I've evolved a little bit from that. But yeah, I agree. Sorry?
We learn and we grow, don't we?
You know, when you first do something, you do everything. You just throw the whole kitchen sink, and now it's a lot more refined to what I used to do. But yeah, I agree.
So quickly go through the Sliss stretch. And
start in a standing position, holding onto a wall for support.
So,
step the affected leg backwards, keeping the toes pointing forwards. Bend
I
the
don't
front
like
leg, moving your body
Sliss
in this
stretch
direction.
like that. I find it really difficult
Hold
to
this
do myself.
position and allow the back knee to soften. Your heel may come up a little. You should feel this stretch lower down in the calf near the tendon.
So you generally tend to feel the stretch lower down, don't you?
Yeah, I don't like this. I don't like giving this stretch to many patients because it can agitate. Briefly before we go on to this exercise, with the last two exercises, you can make that a lot harder by adding a book in the into the forefoot area of your foot, and then putting that. Yeah, so you're pushing it up, and then you're doing the stretch. I sometimes, before I get them onto a book, I get the door wedge, those like rubber wedges, and I get them to put it onto the big toe moving down, because that actually works great as a wedge, and then I make them do the stretch. It becomes a lot more effective. But yeah, what is this, Tausif?
This is similar to,
stand up straight on a step, facing a wall or supportive surface.
So I send to my patients exercise, so they have the videos to be able to play and follow the exercises.
On the towel. Stand on your affected leg and perform a calf raise, pushing up onto your toes. Hold this position. Control the movement as you slowly lower your heel back down over the edge of the step. Ensure you keep your knees straight throughout the movement.
So that's my favorite exercise. This is for plantar fasciitis anyway. Right. So I'd be interested to know, like, in terms of your progression and regression. Like I told you about that, I tend to do these exercises with the patient there and then in my clinical settings to find the baseline. And once I found the baseline, then I would build up on top, because it's quite easy to say that take this exercise, go home, do it for like 2 months and you'll be fine, and do it every other day, and these are the numbers that you need to do it. But we know that you need to be progressing, don't you? We know that you need to be progressing, and we know that everybody might not be at the same stage where they can do these exercises or they can't do these exercises. So that's how I determine. So in terms of progression and regression, what do you do?
So I do the same thing as you. I do demonstrate it and I watch them do it, and then I'll go through it. Sometimes I will record them using their phone so they have a record of it, as well as sending the videos that are but sometimes if you've got a video of yourself doing it and me telling you, don't do this, don't do that, it sort of gives them a good reminder. I tend not to tell patients to do it every other day. I tend to start off with every day. Because I find that they don't do it every day. They tend to do it every other day. So if I start off with every other day, then they'll do it once every 3 or 4 days. 1 to 4, if they're in that much pain and like discomfort. And then I just, as you rightly said, I'll tell them to dial it back. Now, as when we spoke about other rehabilitation programs, and I said how we need to have the end goal in mind. It's very similar to heel pain. So I would try, if I am rehabbing an athlete, I've got that end goal in mind, that they are going to run a marathon, or they're going to run an ultra marathon, or play football, and I'm slowly going to try and progress them quite quickly onto more aggressive rehabilitation as soon as I've taken them out of that initial painful window. So that's my views on that progression.
Mhm. Well, in the history, I look at what causes them irritations and then modify them activities. I still get patients, surprisingly, I still get patients who are runners, and they come to see me and they say that, oh, we've been to another healthcare professional and we've got heel pain and they told us not to do it. And I thought, okay.
Not to do.
Not to run at all. Not
Oh,
to do this activity at all.
no, okay. We don't tell people not to run. We just tell them to dial it back.
I certainly don't, because I think I go through a lot more detail in terms of what causes the problem, and these are little things which I can actually use. So rate of perceived exertion is a really good one, where they've done an activity, they know how hard the activity was, and then they score their pain as well on there. And if the pain stays in a comfortable sort of area, then I'm happy for them to do them activities moving forward and just rehabilitate their plantar fascia. If the pain exceeds that, then we start to look at changes. As you can actually see on the pain scale, the changes can be, we might reduce the rep, we might reduce the range of movement, we might increase the rest time, we might, rather than doing like 4 times a week, we might do like twice a week. Set, frequency, speed, weight, all these things we can basically manipulate, and then you just keep building it forward, can't you? And this gives, and I think personally, for what I've actually noticed is that since I've started using these things, patients are on board with the rehab, patients are on board with the stages of rehab that they are at, and they know that it's them who are leading the progression or regression. It's not anybody else. It's not me telling them, right, do more, do more, do more. It's them who are in the center of it.
There's actually some evidence regarding this, and I can't remember the paper off the top of my head, but they are better out if you make the person in charge of their rehabilitation and you make them feel ownership of their rehab, they will get better outcomes than you just prescribing something quite rigidly. So there is a paper written on that. I just can't remember off the top of my head, but yes, you are right. You are right.
I think I feel like as a clinician, my role has become a lot more of an educator rather than the person who basically puts their hands on and fix things.
Okay.
You don't seem to agree, Abid.
No, I agree. I think it's a mixture of both. I think education should form the baseline for all your interventions. But I'm not of the, as some of my colleagues are, I'm not of the opinion that education is enough generally.
It's not enough, but I think we're at one stage, I probably were 80-20, where a lot of the therapies that I was doing in the clinical settings, hands-on and doing myself, that number has actually come to possibly like 60-40.
Okay.
Right, so footwear, orthotics. Now footwear, if you've got heel pain and you're walking around barefooted, if you've got heel pain and you're wearing flip-flops to walk around everywhere, that is not a good thing, is it?
Tausif, the classic is, although nobody's going on summer holiday this year, you're all stuck here. You're not even going to Brighton. You're stuck, right? Classic is, people go on holiday, they get flimsy flip-flops, they walk around for hours and hours, and they don't feel the heat because they're in 30-40 degree weather or whatever. So they don't feel the pain. And then when they come back, they realize they've agitated the plantar fascia, or they've been walking on sand on a beach somewhere, and their intrinsic muscles in their feet haven't worked that hard before, and they've got it. yeah, I mean, the classics are obviously high heels and things that may strain your foot, or I don't like these Vans thin plimsoll kind of shoes.
I want to ask you about your thought about these flimsy sketches.
Ah, I've evolved. I've evolved. I used to hate them, but now, in the last couple of years, they've got some good models of sketches. So generally speaking, if you can bend a shoe like that and twist it like that, is no good. But that being said, once we put an orthotic into the shoe, you're not bending it. So like it's that kind of trying to find that balance. Generally speaking, you want a shoe that is going to be like a stiffer around the heel and the midfoot, and has a little bit of bend at the forefoot, but you shouldn't be able to bend it. So ladies, especially Asian ladies, they wear these very flimsy ballerina shoes. They drive me mad. And you know, when they walk into clinic and they've got that, I was like, you know, what did you expect? You're walking around with like 2 millimeters of cushioning, if that, right? And then it's that wear and tear. So I often describe it to them. I go, it's like you driving around in a car and your tire is worn down from one side and you just keep on driving because your tracking's off. But yeah, footwear is one of those discussions that podiatrists are having that we don't want to have because it's common sense.
Well,
But, what do you think?
What drives me crazy is when they say they come in crappy shoes and they say, these are the most comfortable shoes I have.
I've got. Oh, I've heard that so many times.
Oh my God. And I instantly know that my job with regards to the footwear is going to be hell of difficult to somebody who comes in a decent shoes. But yeah, I think the sketchy shoes, which are really, really softish, which bend around everywhere, I really don't like them. I don't think they provide enough support. The reason patients really love them is because they're nice and cushioning, that they're feeling the sensation that they get like they're very light, that they haven't got anything on their feet and they can walk around quite comfortably, but they're not giving any functional control at all.
I think Tausif, sometimes it's, so say for example, they've come to you in a thin ballerina shoe and then taking them from that to a very supportive shoe, maybe too much of a jump, okay? So sometimes something like a Sketcher is like, it's still a crappy shoe, right? It can be, but it's not as crappy as the other shoe.
Yeah.
So it's a progression rather than...
I would still prefer, I wouldn't put them in Hokas or something, but I would still prefer something better than Skechers. I usually have this analogy where I say that if you can see like 2 different colors on the sole of the shoe, especially when we're talking about the trainer, I'm happy enough with it, because generally you have a midsole which is cushioning, but then they have like a different colored EVA underneath, which gives a nice sort of push off. And that's what I want. I don't want that sort of feeling where they have got a really cushioned shoe. It's like walking on the beach analogy, where you keep digging in. That delays your, when you do heel strike and propulsion, it delays that next stage of your gait. And your calf need to work really hard to be able to pull you out and then push you forward. So I from that sort of point of view, I think I generally have a trade-off with them, and I say to them that I want you just a couple of months, just focus on a shoe which is comfortable, which is supportive, wear that as much as you can. And I tend to use that as a bet, that if you do these things early enough and quickly, you'll get rid of the plantar fascia, and you'll be able to, once you've done your exercises, you'll be able to do whatever you want to afterwards. You don't have to stick to these ugly looking shoes, and they tend to buy that.
Okay.
They tend to buy that. Orthotics, again,
Let me see if I've got a pair here. 1 second. So I'm surrounded by orthotics because I'm in my office. Okay. Okay, so I have got a pair here. Now, let me go through. These are the Dr. Pro insoles. If you don't know who they are, I invented them. But anyway, I'm not going to talk about them too much. These, I like this particular model that I made for a patient. This has got a medial flange at the top, which offloads the fascia. It's got a 4-degree heel wedge, and it got a reinforced arch. Sometimes
keep the orthotic down, because we're actually seeing your background in the orthotic. We can't see the orthotic, and we can see the.
You know what? It's green. That's why it's green. So it's fixing into my green screen. But generally speaking, I've got other colors here as well. But so this is this will work. This is a blue one. Okay, so these are Dr. Sports insoles, which I also designed, but we don't talk about that. So this has got a wedge on there as well. But generally speaking, offloading the fascia with an orthotic can be highly effective. What do you think, Tausif? I'm going to advertise this while you're talking.
Of course, you can know it. For me, I think the orthotic is very individual. I don't think of a generic orthotics for everybody. Basically, I always think of, what is the contributing factor to the plantar fasciopathy, and then provide them controls in an orthotic to be able to correct that and help support that. But the main function that we want from an orthotic is cushioning, improving function, and that's what I've talked about. That if I see that the function of the foot is hampered, that's what I'm trying to support there, and it's a great pain reliever.
So what I might do is I have quite a prescriptive nature to if they've got plantar fasciopathy. They have a lot of cushioning around the heel, so I'll get the lab to put more cushioning around here. So there'll be like red pour on and yellow pour on cushioning, 2 different layers. The arch support has to be semi-flexible. I don't like a hard arch support. As I showed on the other one that's green that you can't really see, I tend to ask the lab to put a like medial flange which goes up the arch. It's very soft cushioning. I may or may not put a wedge on the inside. It depends, very much depends. But the orthotics can work really, really well, especially if the patient agrees to wear them for 6 months. What's your view on semi-custom or custom orthotics for this?
Again, if they've got a sensible footwear, and I can achieve the things that I want to achieve from a semi-custom orthotic, and it would fit into their shoe, and then I'm more than happy with that. But if they require a orthotic which basically need to be fitting into smarter shoes, and the activity that they're doing requires further support or long-term support and stuff like that, then I'd advise them custom orthotic.
Okay, cool. Do you want to move on?
Injection therapy. Now, I have looked at the injection therapy for the plantar fasciopathy, and what I do in the clinical setting is that, again, steroid injection. Now, we've talked about that plantar fasciopathy, not the itis. However, steroid injection is widely used for plantar fasciopathy in early stages and provide a great sort of pain relief for short to medium term. I use that quite often in the clinical settings, especially when patients come in and they can't put their heel down on the floor and they're really struggling. Rather than having the anti-inflammatories, I tend to go through with the steroid injection. That gives me an opportunity to be able to get them to start doing the exercises and rehabilitation and get back to the normality of life. Any other time that you would use steroid injection?
I do. I use steroid injection quite a lot. One that you didn't mention there is like biotherapeutic agents. So Trumeal and Guna, which are like homeopathic remedies, which I find really, really good.
I was going to talk about Trumeal and Zeal. I know you use some of them, don't you?
I use Trumeal a lot. There's another brand called Guna that they can be very so they've got very few side effects, and I think they can be very effective. Now, two things to mention here. First of all, when me and Tausif talk about injection therapy for this, we are talking about ultrasounded guided injection therapy. We find on ultrasound, we find the area of the fascia to the millimeter where it is very thickened, and we are aiming in that area. Another thing, Tausif, are you giving them an ankle block first, or do you just go straight in?
I have given ankle blocks before. That gives me an ability to kind of do a little bit of peppering, and I can get there a lot more easily, even if I'm using ultrasound guided injection, sometimes it can be a bit fiddly. So when I give the ankle block, I don't really worry about anything else. And then I do use ankle blocks often.
Now let's just make sure everybody knows what we're talking about. When we say ankle block, we are giving an injection in your ankle to like knock out all the nerves on the bottom of your foot before we do the heel injection. Now, if you went to a GP, they may just do the heel injection and they may go straight underneath. That is the most painful injection you'll ever have in your life, and it is immensely painful. I don't like giving my patients pain, and nor does Tausif, so we tend to give ankle blocks first, which enables us to give this injection pain-free. And the ankle injection is not painful at all. You won't feel it at all. Also, you mentioned pecking. I think so when this is the benefit of visiting a podiatrist like me and Tausif. If a GP was to do this, they would go in with a needle one time, do the injection, come back out again. We know, because of our knowledge of feet and the fascia, that the fibers of the fascia are disorganized. So while we're in there, we're actually moving the needle around different angles, and we're trying to break up the fascia as well. That encourages healthy healing of the fascia also. Which is what I mean, like how one of the things I said to you before, that it doesn't really matter what we inject in a way, because it's the technique of the injection that's going to make it better. But a cortisone injection can be effective for plantar fasciopathy.
Now, regenerative sort of injections like prolotherapy, PRPs, they are lots of good evidence is coming through with these injections, and they are proving to be very sort of good for long term.
I've done hundreds of prolotherapy. So when we say prolotherapy, we're talking about getting injectable glucose, mixing it with local anesthetic, so it becomes 25%, and we're injecting it into fascia. Great, absolutely great. I've only done one PRP injection for plantar fasciopathy, and I'll tell you why I've only done one. Because in my hierarchy of injections, I tend to put this at the top. So I will try other injection therapies first, because with PRP, I have to take blood from your arm, and then I've done this in the past where the patients fainted when I've taken the blood from. Then I've got another problem. So I try not to go down this route. I do PRP a lot more for knees than I do for feet, actually. But yeah, regenerative therapy, there's good evidence for like glucose.
What I was going to say is that I do PRP injections myself, but in terms of the evidence and the potential side effects, as well as long-term sort of helping for the plantar fascia, is there's good evidence there, isn't there?
Yeah, there's really good evidence. Yeah.
Now, final treatment therapy, shockwave therapy. Now, shockwave has actually become quite famous in the last few years, hasn't it?
It has. Everybody's got a shockwave machine.
Everybody, well, in podiatry world, I think everybody that I know is investing into a shockwave machine. They're not cheap things, are they? But they have got a very good sort of, very promising evidence which is coming through for not only the early stages of plantar fasciitis.
There's some good evidence regarding it. Tausif, are you still there? Or are you broken off?
Can you not hear me?
Hey, don't crack. Don't leave now. Not right at the end. Tausif, can you hear me?
I can still hear you.
Oh, okay. I think it's actually my internet connection. So if that's the case, I do apologize. I'm having problems with my internet connection today. Sorry, you said something about shockwave.
Yeah, there's some promising evidence with regards to the shockwave and plantar fasciopathy, isn't there?
There's some great evidence. There's some tier 1, level 1 evidence regarding the use of extracorporeal shockwave treatment for the treatment of plantar fasciosis. I spend a lot of time in London, and at the Mile End Hospital, everybody gets three sessions of shockwave treatment, and I've spent a lot of time observing them. They all get around about 2,500 shocks. The intensity varies depending on how much the patient can cope with. It doesn't take long, takes 15 minutes. Can be very effective. In my experience, it takes more than 3 sessions. It takes
I agree.
5-6 sessions. It can be very, very painful.
So a shockwave therapy, what is it? It's generally mechanical high energy sound waves which are applied through the skin, and yeah, they help to increase blood circulation and activities in the cells in the treatment area, which helps to speed up the process of healing and happens to break down the scar tissues in the plantar fascia. But yes, all the patients that I don't do shockwave myself, but in our movement therapy clinic, we've got Mike. He does shockwave therapy. Excuse me. And all my patients who have been through it have reported that it does hurt.
Yeah, look, it is effective now. Some patients are okay to come to the clinic 4 or 5 times, 6 times. Others cannot commit to coming to the clinic for 5-6 weeks in a row. So this is highly dependent upon the patient. If a patient asks me, does it work? I'll say, yeah, of course it does. I do offer it. I do provide this in our clinic. It really depends on how much time the patient has.
Yep. Now that has actually come to the final thoughts. Now, excuse me, you talked about acupuncture, and that gave me an idea that in terms of final thoughts, plantar fascia release surgery, again, not very common. It is a good viable option for patients if everything fails, but I haven't seen many people fail and get into a surgery stage myself. What about you?
I have yet to send anybody for plantar fascia release in the last 25 years. I have never sent anybody. I've managed, touch wood, I've managed to get them all better. But it is an option. I know colleagues that do send patients for plantar fascia release. And if all else fails, then that may be an option. I think those cases, now this is interesting to see, if those cases that you and me both have experienced over the years that are not getting better, we've thrown a kitchen sink at them, they're not getting better. We may then go back to square one and make sure our diagnosis is right. Make sure there's not something else going on in the body that we've missed. And I can hold my hands up and say, it's happened to me a few times where I've gone back and I've taken more of a detailed history and I've realized they've got an inflammatory condition that hasn't been picked up by the GP or anybody else. And it's just manifesting in a shoulder or in their wrist and their foot. And yeah, that's taken me aback. Well, what about you, Tausif? What about surgery, and what about those cases that haven't resolved?
Again, surgery, again, I am yet to actually send somebody for surgery, but I have had few patients in my clinic where they have had surgery with a fairly good sort of success rate. They've tried anything and everything, and nothing kind of worked. With regards to getting patients when you're just kind of doing stuff and nothing's working, yeah, back to drawing board. What I've actually evolved as we learn and we grow, when I graduated and somebody comes in and says to me that, right, I've got pain first thing in the morning, I've got this, I've got that, and instantly I know in my head that is plantar fasciopathy, and that's what you do. And especially when you are in the NHS and you are pushed by time and you haven't got a lot of time to basically spend with the patients, and you just cut corners and you end up doing things. But with the experience, now that my assessment is a lot more thorough, my history taking is a lot more thorough, and it's like Mike talks about, like that sieve. So you kind of sieve through things that we know that it's plantar fasciopathy, but then what we tend to look for is the other things that can be there, or what it is not. So you still test for what it isn't, basically, and that can narrow it down. So you improve, don't you? But yes, I've actually had somebody with the AS who had heel pain which wasn't diagnosed, and
what is AS?
Ankylosing spondylitis. I had that, and we had to send him back to the GP, and then discovered that he's got ankylosing spondylitis. Once we got the diagnosis right with that, and once he got onto the medication, his heel pain disappeared. I had somebody who wasn't my patient initially, but she came to see us after being to few podiatrists, physiotherapists, where she had heel pain, and it's been a long-standing heel pain. She had all the orthotics under the sun. She had all the exercises she's been doing. She's the footwear chain, and these things give you a clue, doesn't it? That if you've tried all these things and things aren't working, it's probably not plantar fasciopathy, is it? And then we discovered that she had lumbar impingement in the back, and she had to go through to a surgeon and corrected that, and her heel pain disappeared.
I had somebody last year actually who had been around the block for heel pain, and he actually had, when you actually spoke to him, he had numbness on the outside of his heel, and his pain was on the outside of his heel. Now we know that's not plantar fasciopathy. This guy has been having steroid injections. He had 3 steroid injections on the inside, all right? 3. He had NHS orthotics, NHS injections, shockwaves, not getting better. So when I did my neurological tests on him, I knew he had like S1 nerve root compression. So we started to, you put them into like a slump test and the straight leg raise, and they light up, all right? So they're in pain. You should never get pain from doing a neurological test of your back in your foot. So yeah, he got sent to a colleague of mine in Birmingham who's a top physio, Isaac, his name is. He's in Erdington, and we worked on him, and he got better quite quickly actually. But yeah, okay, so thank you very much, Colombo. Thank you very, very much for this awesome presentation. I am highly impressed with, do you want to switch off your screen share for a second? I'm highly impressed with your graphics, your presentation, and your backdrop, and your transitions and your slides. I'm feeling quite like I'm not good enough anymore. I feel insufficient now. It's really working on my ego.
I must say to you, this is after you teaching me all these things, and they finally, after years of nagging me, they finally have come to life.
Let me clap. Finally, but like but now you're taking the world by storm. Okay, so what are we doing next week? I am doing exercise-induced leg pain. Brackets, don't you dare call it a shin splints. So that's gonna be my presentation, and it's gonna be in depth. What are you doing?
I was gonna do tib burst dysfunction. That's gonna be my task. But I think we ought to cover Achilles tendinopathy as well. I think that's one of the things that we see all the time.
On the week after, before we head back to work, which will probably be 7th or 8th of May, me and Tausif are opening up again. Tausif is going to be at the movement therapy clinic and the podiatry clinic based in Harborne, and I am going to be in the custard factory in Birmingham. And we hope to see many people after this lockdown is over with, because we need to see patients because we're going mad. we need to get our hands onto some feet and to diagnose and to treat, because that's what we do, don't we, Tausif? That's what we're really good for, good at rather. Any other final thoughts?
No, that's fine. I think
I mentioned my t-shirt, man. Look at this.
So I don't know how long this video have been.
You haven't mentioned my t-shirt?
Oh gosh, spiritual gang. I love that. I need you.
I have to, trying to get a compliment out of you is so hard. It's just unbelievable. Okay, we shall speak to you soon.
Okay.
Thank you.
I'm gonna stop recording.